All right, so chemotherapy. All right, so chemotherapy, like I said, I'll try to get it to you as simple as possible, but chemotherapy is 80 years of chemotherapy, and the last 20 years has all been newer agents, but you're always tested on on these older agents that are still being used. Like we use the older agents for, stem cell, right? For myeloablative therapy. Some of these different meds we need to know, are going to be shutting down the immune system, shutting down the bone marrow, or they are very, very toxic, all right? So we have to know those toxicities. So the last slide will have a lot of those toxicities that you need to draw pretty much every day. Just draw these, just head to toe. These are the complications of these different medications. The same thing, another head to toe stick figure of different general chemotherapy complications. Like just going head to toe, I got alopecia, then I got a sore mouth, then I got I got rashes, all the way down till you get to diarrhea, basically, right? So we'll go through those and try to explain and point out, just like antibiotics, I made tables that hopefully makes it a little more succinct, so you're not going back and forth on different slides trying to figure out which one's which. We do have to recap the cell cycle from biology, right? So the mitosis and interphase and prophase, metaphase, anaphase, telophase, all those things, and the different cell cycle pieces, the G0, G1, synthesis phase, all those fun stuff, right? So that's how chemotherapy is kind of organized. That's how it interacts with the different cell cycles. It arrests the cell cycle, makes it stop, and it makes the cells that are proliferating the fastest stop, right? Which are usually your tumor cells, but it's also your hair cells and your GI cells and your bone marrow as well. If you're producing 2 million RBCs every second, that's going to shut down pretty quick. Okay, so chemo overview. So chemotherapy or antineoplastics or chemotherapeutics, they're going to directly or indirectly inhibit fast-growing cells. So here's an example of fast-growing cells here, right? They're growing fast and fast and fast, and you can graph that on a curve. You can graph how fast they're growing. And we want to reduce that fast growth, right, with chemotherapy. So every time you get chemotherapy, it's going to shut it down. But like we saw with leukemias, they can remiss, or that's remission there. They can bounce back up. They can reactivate, right? So we have different chemotherapy regimens. We'll show you a few of them. A few of them we talked to you about, like with colon cancer, we talk about FOLFOX and FOLFIRI. So we'll kind of describe those. Once we've introduced to you, you know what F stands for and what OL stands for and what leucovorin stands for, right? So the goal is to target rapidly dividing cells, the ones that go through mitosis the fastest. That's usually your tumor cells, but we're going to make mitosis difficult, right? And how to make it difficult, we can stop RNA and DNA from even assembling in the first place, or if we do have DNA and RNA, we can prevent it from even separating. If you can't separate DNA and RNA, you can't, the cell stops, right? So other things that will be affected by this, right, are nausea, vomiting, and this slide set, nausea, vomiting is highlighted in this little dark green vial color, right? Those are that's a common side effect that we have to manage. We have to know what kind of antiemetics to give if someone has profuse vomiting, okay? And that's called chemotherapy-induced nausea vomiting. It can happen up to 5 days after their initial treatment. They get chemo on day 0 up to day 5. They can keep having significant vomiting, right? And then bone marrow suppression. So I've highlighted in gray for bones, I guess. I don't know. Highlighting in white wouldn't really make sense, right? So highlighting in gray, and that's going to be meds that really, really suppress the bone marrow. There are a few that don't, like 100%, but you can always assume that they're going to be high risk for infection whenever someone's getting chemotherapy, right? And then also when you shut down the bone marrow, then you have the opportunity for something like AML to develop. You have different leukemias that can develop when you do shut down bone marrow. Okay, and alopecia and infertility, and we'll talk about these more, but these are all just examples of things that produce so rapidly. Like anemia can develop because you're producing, again, 2 million RBCs every second. That's going to shut down. You're going to be anemic, right? Sperm cells, right? High five, 1,500 per second, right, are being produced. So that's going to shut down real quick, right? That's about the same amount as these tumor cells might be producing. So that's going to shut down as well. All right, there's different toxic chemotherapy agents, and we can give medications to fix some of the side effects. These 4 right here are the detoxifying agents. So wherever in the slide set you see this bright green, that's a detoxifying agent, and these are the 4 detoxifying agents, right? So leucovorin is usually attached to methotrexate, and mesna is attached to these 2 right here, cyclophosphamide and ifosfamide, technically. It's that ifosfamide in there. And we'll talk about those. And amifostine is for platinum agents, and we have dexrazoxane is for your antibiotics that didn't make the cut, right? So we don't use antibiotics anymore because they were so toxic. They cause apoptosis. They cause infertility. Such as a hard cell. So I know you got a UTI, but we can just wipe it out. We can make you infertile. So that's not going to be a good selling point. So they found a home in chemotherapy, right? So they literally are stopping the bacteria, yes, bacteria also, but they're stopping the normal cells and tumor cells from even separating, okay? So we'll talk about those. And then chemotherapy. So our goal is to reduce that curve, that speed at which this is traveling up. We're going to shut it down and put it into remission. So this is remission down here. This is active disease up top, or active cancer up top. So the chemotherapy's goal is to bring it down, right? We can bring it down just with treatments, and sometimes you're good, like skin cancer, you're done, right? But other things are like colon cancer, pretty much you get like 21 days, you're done, right? But something like leukemia, it's like 2 to 3 years. And sometimes it doesn't work, and we have to ablate their bone marrow and start them brand new, right, with stem cell transplants. All right, so resistance. So just like bacteria develop resistance, our tumor cells develop resistance. They are actually our cells, so they're smarter than bacteria. They develop certain channels to push out the chemotherapy. They misshapen the targets of the medications. There's all kinds of different things that a chemotherapy drug can get resistant, or our tumor cells can become resistant to. Okay. So there's a little overview of the symptoms that we'll talk about in more depth. Right, they're obviously not going to want to eat much when they're vomiting all the time, and also the GI tract is not able to absorb great because it's all the cells are kind of like with our we talked about with anemia. They have the swollen tongue. It's like through the whole GI tract. They're not going to absorb things that great. There's an example of some of the antibiotics. Well, yeah, antibiotics are on there also, but the example of some of our chemotherapy agents. You can start all the way from the purines and pyrimidines. Those guys are what make up the DNA and RNA. And the DNA and RNA has to then go through the cell cycle, right? You have to unravel the DNA, make copies of it so you can make 2 cells eventually. You unravel it and then you put it back together. And sometimes we have things that prevent it from being put back together. And then we prepare for mitosis, and we have things that will stop mitosis. There's different checkpoints also along the cell cycle that we can manipulate, right? And force the cell into apoptosis, or force the cell into not proliferating. All right, so chemo delivery. So how do you deliver chemo? All right, so it can be persistent, and that would be because someone's health or age, their bone marrow capacity. Sometimes a younger person might bounce back much faster than an older person from chemotherapy. There can be liver kidney function, and we'll point out the ones that damage our kidneys, the ones that damage our liver. Right? And of course, compliance. This is not an easy sell. You're going to be infertile, you're going to lose all your hair, you're going to have nausea and vomiting for 5 days, and you're going to have explosive diarrhea for a long time. It's not an easy sell to be on chemotherapy. There's different cancer factors we talked about, the growth, how fast the cancer grows. There's resistances out there we mentioned, and of course the stage of cancer. Obviously, chemotherapy is when we have metastasis, when it has spread from the organ itself into the bloodstream, right? That's usually when chemo is started, right? There's some rare cancers like testicular cancer. You're going to start it like right away. Once you see it, bam, we're going to either take them out, or we're going to start them on the cancer therapy or chemotherapy, and we'll get rid of it. It has a great cure rate as long as it has not metastasized. Okay, so routes of chemotherapy, IV makes sense, right? That's the most common, right? It's a very, very potent drug, so we're gonna give it IV. Sometimes just day 0, and you get the antibiotics. You might get one in 21 days, but it's just that one-time deal you have to muscle through. But like other ones, like leukemia patients with acute leukemia, they have to get a central line placement. They have to get repeat things for like 2 to 3 years, right? So portacasts are an option. For repeat, you can do up to like 2,000 pokes with a Huber needle into the little port there. We have PICC lines are good for like 3 to 6 months. We have Grosjean, Broviac, and Hickman catheters. They look like PICC lines, but they're some of them are special designed. Like Grosjean is special designed to not be heparinized. All right. There's topical chemos for cancers, for skin cancers. There's intrathecal. Where's your thecal at? Your thecal is your spinal space, your spinal column, right? Your CSF. So if we introduce something into the CSF, that's called intrathecal. So a lot of chemotherapies do not cross the blood-brain barrier, so we have to go directly there. We're going to punch a hole into the spinal column, and we're going to inject the chemo directly there, right? And then oral. So sometimes, usually for maintenance therapy or palliative treatment, like the chemo is too far gone, we're just going to shave off the bulking, so we're not able to get to cure the patient, but we're able to kind of suppress it enough so they can live out and with symptoms, but we're going to reduce the symptoms as much as we can. All right, so chemotherapy and extravasation. So we mentioned this before the IV push, that there's you can slap the patient, right? You slap them, and that's going to do what? That's going to hopefully reverse the extravasation, because it can be a very, not deadly, but it causes infection, I guess, but a very, very deforming injuries, right? So S is what? It's going to stop the infusion as infusing. We're going to leave the tubing in place, the catheter in place, so we can aspirate out any medication that might be there. We're going to aspirate it out. And then P is provide the treatment, right, or plan for the treatment. Usually it's ice, except for one set of chemotherapeutics, and that's your vincristine, or your vinca alkaloids. Those have vincristine, vinblastine, and other vin. But vincristine, you think of crisp, right? So vincristine crisps your nerves, it causes peripheral neuropathy, but also in extravasates, you provide crispy hot packs. So that is the treatment for that one. Everything else is cold packs for everything else, right? But the only exception is the vinca alkaloids. And to be cautious that vinca alkaloids are different than alkylating agents. So those are two completely different chemotherapies. So we'll point that out as well. And whenever you see extravasation here, in this little fire color, that's going to be on our different tables. That usually means these things are going to carry over, right? Dexrazoxane, you should already remember from the first slide. That's for your anthracycline antibiotics. There's 3 different antibiotics in this class, and that medication is a treatment for its side effects, which is cardiac toxicity, but also it's for infiltration. So it does both. It's a protective medication for the side effects of that class, but also it's a treatment for extravasation. Okay. I put this thiosulfate here, but we really don't, it's not very common. I can't really see many cancers that we use mechlorethamine, but it's just there as an FYI. But anthracyclines, we're going to see those a lot. And then we have vinca alkaloids. So vinca alkaloids are vincristine. All right. We apply what kind of compress for crispy vincristines? We apply crispy hot packs, right? And we give hyaluronidase. Hyaluronidase is actually used a lot in the 90210 to like lip injections and for lip fillers and eye fillers to get rid of the eye bags. It just goes through all the collagen and destroys it, so that then you can actually heal up. Cool. But anyways, you have this is also used to break open all the skin, so you can actually aspirate out the medication. So instead of it causing localized necrosis, we can spread it out so we can actually fix it, and the hot packs will help it reabsorb. Okay, so it's really to like break everything open so it can reabsorb as fast as possible. When you give the ice packs and the heat packs, it's usually for like 3 to 4 days, right? Or sorry, 2 days, so 24 to 48 hours. The topical DMSO is usually, it works for everything basically. If someone has an extravasation with chemo, we apply this DMSO pretty much all the time, and that one is for about 7 days. All right, so this should make sense. We kind of summarized it there. So vinca alkaloids are where on this list? They are over here. Okay, and these guys are the ones that we would give what? We give warm packs, and what else? Get hyaluronidase. So here's warm packs right there. All right, that's for your vinca alkaloids. Your vincristine, vinblastine are the most common ones. Okay, everything else is cold packs, right? Everything else, topical DMSO. Okay. The only exception is our anthracyclines. We can throw some dexrazoxane at them, and that's also one of our agents that is used to protect the heart in patients that get these anthracyclines. All right, so chemo precautions. If someone's getting chemotherapy, it's not just like regular isolation, put a mask on. You have to make sure there is precautions in place. So the nurses are specially trained to give this. This is not something you're going to be giving. This is, you have to get a certification to give chemotherapy because it's all about the proper administration and also the previous slide to make sure everything's done right in case of emergency. But also it is for a, what else? It's for a potential spill. So if you have a spill, then we have to know what to do. So if there's a spill, we might have to we have to put N95 on because it's a hazardous material. It's literally a lot of our alkylating agents, which are our first chemotherapy drugs, are literally mustards from World War I that inhibit cell division. So that's pretty important. We don't want to cause a mustard bomb to go off in the hallway. All right, so we have to put N95s on. We have to have special chemo gear. It's usually in the med rooms. If you look for it at the hospitals, they'll have it there just as a just in case. All right, it's usually like a yellow hazard kit for spills. And special people have to know you can't just call EVS and they come up and mop it up. That's not cool. All right, so you have to special agent has its own little specific cleanup routine. Okay. So pharmacy will identify it as a high risk. They'll special deliver it usually, and they'll tell you exactly what to do with it. But you can guarantee you're going to be doing double everything. So double mint, double glove, not double gown, but double flush, double what else? Double bag, double glove, double flush, double chemo precautions for double days. All right, so basically for 48 hours at least after they got the chemotherapy, they need to wear what else? They need to be doing all these things, right? Especially the patient. So there's inpatient instructions and there's outpatient instructions. What do you do once they leave the hospital? What if they leave the hospital with PO chemotherapy? Well, if they just left the hospital with just like an IV dose, just 2 days of precautions. But if they left with PO chemotherapy, obviously keep it out of reach of children, right? They want to make sure they are toxic for 2 days after their dose, so they have to be using condoms. They're not going to double condom, but don't get pregnant, don't breastfeed. All right, wash with soap and water. If secretions get on them, right, they're going to make sure that they are extra cautious outside of the hospital. Okay, so just like we had regular isolation, these are enhanced isolation. This is just a regular yellow Fisher-Price gown that you got from the Dollar Tree, right, from like the little Dollar Tree. Was it table covering, tablecloth? This is an actual, like it resists chemotherapy. And the gloves have to be chemo gloves. Those nitrile gloves, they have the purple ones, they usually are, but you have to do double glove on those. They should be wearing a face shield if they're administering it, right? Or they're dealing with any kind of secretions. And if it does fall on the floor and aerosolize, they should be getting an N95 real quick.